Hello everybody, Peter Frampton. The title of this talk is Keeping the Wheels On, Extending IP Skills While Prescribing Safely in the Community. I was asked to do this talk at Optometry Tomorrow earlier in 2018 and it went over very well. I was asked specifically because there's a lot of people doing independent prescribing now and there's a great range of confidence levels, I think, out there in the community. And because I've been doing it for so long, they asked me to do it. And I was given feedback. Now, before I go on about it, I want to just read out a little bit. Most of it's all good. Things like, always great to hear Peter speak, smashing, wonderful. Insightful and challenging, great to hear from a practical knowledge in the field. Very interesting, thought-provoking, please invite him back. Yay. And then one, Peter is always entertaining. Yay. And then here one, not enough evidence and more personal views. Two people said that. And that's a fair point. And that's what I really want to say before we start this talk. A lot of it is personal views. I've been doing this for a long time and it is based on evidence, but again, you create what you do in your practice based very much on what you do and how confident you feel. So I'm afraid, yes, it is some of it. You don't have to accept it. And indeed, I think that what I'm telling you about in my practice here is my practice. It's how I've structured my practice. Now, you might work somewhere else and the structures that I think are really important, you might not think are important, or they might not even work. So it is just an open conversation. I certainly don't mind if people don't take it on board. But certainly I've been prescribing really proactively now for nearly 20 years via GPs initially. I became an IP optometrist in 2009, so I'm one of the first. Well, I was one of the first 30. So we've been doing it for some time. So my evidence is quite good, I think. So at the same time, I want to show how you can also raise your red line. You know, we all have a red line. We practice out there. We don't necessarily have as much support as, say, a hospital optometrist will have, who can pop next door and just get a bit of information maybe. We have to work to some extent in isolation. And at that point, how do you keep extending your skill base? And again, that's what this is all about. Now, you might decide to extend it in different ways to me, but this is how I've done it in my practice. So that's why it's called Keeping the Wheels On. So my mantra number one is basically I simply, in myself, I'm asking the question, what's in the patient's best interest? And does my clinical management plan differ in a significant sense from a hospital-based one? And if the answer to the second one is no, then actually it's not in the patient's best interest, is it really, to refer them? Why would they want to drive 30 miles to a hospital, in my case, to see someone and sit for 4 hours when I can do it there and then? Conversely, if I'm looking at something, I think, well, this particular lesion perhaps requires a culture, and I'm incapable of doing cultures in my practice at the moment, then it is patently not in the patient's best interest for me to look after them, and I should refer them. And basically, I'm always thinking now of course, that's a big statement. And how do you get the confidence and how do you gain that ability to say, I know what they're going to do at the hospital? How do you know that? If you don't work in the hospital, how do you know? Well, there are definite ways of learning all this, and that's how you start learning. I think when you've passed IP, you've started your learning process. You have so much more if you're in community to keep on learning, and I've certainly done that. My red line is going up all the time. So this is my little bit of I call it Peter's well-oiled machine. And I'm going to pick out a few of these things. So first of all, your diagnosis, and this goes for most medicine, is a working hypothesis. That's it. You've got your evidence, you've taken in your case history, you've looked at the signs, and you come up with a working hypothesis. You've got to take in, and I think this is critical. I think as student optoms, we're told to take a medical drugs, but we don't really do anything with them. We just write them down. We probably don't spell them correctly. But you do need to know about medical assessments and red flags. You need to be thinking about past medications, both successful and unsuccessful. Then you come up with your clinical management plan and really importantly, record your logic. Record all that and you can't go wrong, basically. And then you do your treatment, then you do your meticulous follow-up. And this is critical. This is a mantra in my practice, and I'll show you a case as to why it is. So I'm telling you that. There's no evidence that meticulous follow-up is necessary. I'm telling you that I do it. And then based on your follow-up, you might adapt your clinical management plan and then self-reflection. You've got to think about what you do. When you make a little bit of a blunder, you've got to learn from it. You've got to think about these things, and you've got to find the time to do it. And, fortunately, I work for myself, and I've got a great team with me, and we're able to have time to have self-reflection. But it is actually quite an important thing. So here we go. Outcome audits. This is the first one. And this is really, really important. And this is actually how you figure out that your clinical management plan would be the same as a hospital-based one. You're not going to get necessarily feedback from hospitals. I think a lot of optometrists do get a bit cross that they never get feedback from hospitals. Well, hospitals are pretty busy places, and I think they haven't always got the time. And I think it's much better that you just take control of your own destiny and actually do it yourself. So outcome audit everything, especially when you have referred to the hospital. So actually, all these cases I'm going to show you are to me seminal cases for me. Some of them are quite old, and some people out there who've seen me talk before will have seen these cases before, and they will keep reappearing because they're so seminal to the way I work. These things have made me change what I do through self-reflection. So here's a patient, came to us, had previously been seen by a nurse practitioner for 10 days with a sore eye, was given chlorphenicol, no resolution, and so she referred them to us. You can see his eyes are a bit in poor shape, would say. He's got a lot of dermatitis. He's always got ocular irritation. He's got eczema. He's got allergies, and you can see that his lids are not in good shape at all. But this is what we saw. Now, I don't know if anyone out there wants to make a diagnosis of that. If people have seen me talk before, they already know what it is. So I thought at the time that, well, this was in 2008, incidentally. I was not IP then. And I made the diagnosis that I decided that this was viral keratitis. But because he'd had it for so long, and because it was becoming geographic, it was way outside any of my comfort zones anyway. And back then, and in fact, it still would be outside comfort zones of a lot of IPers now. It's gone on quite long. But back then in 2008, I was an IP, and I said, look, there's no way. And of course, as usual, he was going on holiday. All these patients are invariably going on holiday. So I referred directly to the hospital with a letter outlining the signs and symptoms and previous ineffective medications. I put all that in the letter. And I said to the gentleman, though, could I see you again tomorrow, please, to see how you're going? Now, that's how I always do my outcome audit. And you do it in a very positive spin. You say, right, I'd like to see you tomorrow. Please bring in all your medications because I want to check that everything's going okay. And they think that, well, they know that you find them important and that you want to know. So I booked him in 8:30 the following morning before I started work, and he came back in. And what he told me was, he said, well, Peter, you got that really wrong, didn't you, mate? You told me it was it's virus, and actually it was a corneal abrasion. So that's what the hospital had diagnosed it. And they gave him more chlorphenicol. And this is regardless of the duration of the history, because an abrasion wouldn't have gone on for 10 days, regardless that the referral had stated the previous treatment history. I told them that he'd already been given chlorphenicol for 10 days and it hadn't worked. But at least the hospital did say that they're going to review later the following day, so the day I was seeing the patient. But as you can see at the picture at the bottom, that's what it then looked like. So that had morphed from that really quite classically dendritic type presentation to this more geographic one in only about, let's say, 18 hours. So I was a bit taken aback by this. I really beat myself up about it because I thought, crikeys, how can I get it that wrong? So I reviewed it, and then I reviewed him again. I said, right, well, okay, you're going back. So let's see you again tomorrow, please, if you're kind enough to come in. And I looked at it again. And the next time he came in, it was suddenly geographic simplex keratitis. And, how confident was I? The outcome certainly dashed all my confidence up until that point. But then when he came back in, he finally saw a consultant, I think, who actually said, right, this is now viral, and they treated it with ganciclovir ointment and acyclovir tablets, 400 milligrams, 5 times a day for 10 days. So it was an interesting thing. Initially, it completely dashed my confidence. I really thought, crikeys, what the heck have I done? And then I was proved correct. So 2 things. A, you learn. Now, if you come back, you're looking at their medication, you think, okay, this is what they've done. All right, I'll learn from that. But in this case, it was even more profound than that, because actually it then finally supported my confidence, because I thought, yeah, I am right. I was correct, and I could have treated it correctly. Had I had the capabilities at that time, I would have treated it there and then. So these sort of outcome audits are really, really good in a both positive and negative sense in a way, because as I said, it really dashed me. If I hadn't followed up that more, I don't know what I would have done. But we turned out well in the end, and I learned so much from this patient, so much. So now here's another one. This is about meticulous follow-up. And this is the case that makes this real. This is a 24-year-old contact lens wearer, daily silicone hydrogel, stringent with cleaning, back from Oxford University for a summer break. She turned up with a slightly irritable eye, very slight, 2 out of 10 on the pain scale. She obviously removed her lenses immediately, because that's what she's always been told by us to do, and to present immediately. So just coincidentally, we have a fee pay structure at our practice, and people pay us for our professional services. And they're told, if you've got a sore eye and you're a contact lens wearer with us, you must come in and let us see so we can deal it. Don't sit on it. So she did it. She did everything correctly. Unfortunately, she saw a non-IP optometrist, and this person diagnosed this as a marginal sterile ulcer, which makes sense. It was fairly marginal. It was very small. It was very, very little pain. And he did say, he prescribed it with chlorphenicol, said don't wear the lenses, return in 2 days, but return earlier if SOS. So he basically covered all his pay. He put his logic in, and there's nothing wrong with that. But the college clinical management guidelines, which are a really good resource, incidentally, they describe what a sterile peripheral ulcer would look like. A bit of epiphora, low grade, small, usually small, peripheral, and so on. Usually unilateral, of course. And then it tells you temporarily discontinue lens wear, advise against extended wear, warn about the possibility of recurrence, and so on, lid hygiene, and so on. So it tells you all those things, which is fine. But then it puts in a differential diagnosis, and differential diagnosis is bacterial keratitis. And this is the thing, appearances can be similar, and it says, therefore monitor closely, especially over the first 24 hours, and if the diagnosis remains in doubt, refer to an ophthalmologist as an emergency. And we have to recognise our limitations. So, let's have a look then. What happened? I saw them in 2 days, and that's what I saw. 5mm lesion. This poor girl was hospitalised for 5 days and really lost her entire summer break. So this was an MK, bacterial keratitis. And where did we go wrong? Well, first of all, we didn't follow it up better, basically. Now, there are 2 primary reasons why clinicians fail. This is out of a medical journal that I read, not an optometry one. So this is a generic thing for all people, for all clinicians in hospitals or whatever. There are 2 reasons. One is misdiagnosis and one is under treatment. So yes, we misdiagnosed. But actually, as far as the diagnosis went, there's nothing wrong with his working hypothesis. There was nothing wrong with that. And in hindsight, okay, he underprescribed, but he didn't underprescribe if it had been a sterile ulcer. So his medication suited his diagnosis. But both of those things become untenable if you don't have adequate follow-up. So you can make a misdiagnosis. There's nothing wrong with having a working hypothesis that in hindsight turns out to be wrong. What you've got to have a system in that says, I'm going to review this in a way. So your review schedule has to reflect the worst case scenario. Not what you think it is, the worst case scenario. So if your worst case, if you think it's CLPU, but you think, well, it could be, I think it's unlikely. CLPUs are far more likely than MKs. But if you think that that's an outside possibility, then your review schedule must reflect that. And basically, with the outcome audit, that's when we thought, yes, meticulous follow-up. So this self-reflection has changed what we do. I now work in 12-hour blocks. I don't work in 24-hour blocks even. And if I'm suspicious, we will bring people in more regularly. And I think for non-IPers in particular, they need to. That was a rare situation. This was a very experienced optometrist, but that was the outcome. Now, I don't put that one in ever to scare people off doing anything like this, but most non-IP optometrists deal with these sorts of things. CLPUs are 25 times more likely, aren't they, than MK, but you don't want to have an MK that you miss. So meticulous follow-up always. Now, the other thing that's very, very important is including the patient in the clinical management plan. Now, this goes for virtually everything. If I'm prescribing varifocals spectacles, if the patient isn't bought into the solution, they're not going to accept the varifocals, are they? So the patient is critical. It's their eyes, it's their lives. They have a right to have a say. They shouldn't be pigeonholed and just told as a clinician, this is what I'm doing to you, get on with it because I know best. That is not the right way to do things, in my humble opinion. So here's an example of this. 64-year-old lady presents with symptoms of hazy right eye. It's getting worse, but there's no discomfort. And obviously, she's going on holiday tomorrow. Now, we'd referred her some years earlier for a zoster keratitis, and she is under the hospital review regularly. But her next review was not for 3 months. Her current medication is Predforte, 1 drop per week, and she's not a steroid responder, so she has no medications for raised IRP. She's on some other medications for blood pressure. She's allergic to penicillin and so on. But basically, that's her current meds from the hospital. So that tells you bucket loads, right? As someone who's preparing to treat this, now a lot of IPs would think, whoa there, I'm not handling this one, I want to send off, which would be legit. But I talked it over with the patient. I actually gave her that option. I said, look, I can refer you off. But she said, well, I'm on holiday tomorrow. I don't really want to spend 8 hours in a hospital. So what was my working hypothesis? My working hypothesis was interstitial keratitis, and it's managed with Predforte, 1 drop per week. And we know that from what she's told us. And we know it's not infective, really, because she's on Predforte, which is an anti-inflammatory, as you know. And what's in the patient's best interest? Well, they're going on holiday. They don't want to go to the hospital. So, they've bought into what I'm going to suggest. And they won't come back on that. They know. But I think you've got an empowered patient. You kind of know where you're heading already anyway. The eye's not painful. So because I decided this was interstitial keratitis, when you've got these people on long-term steroids for this stuff, you want to obviously give them the least amount of steroid that'll keep the problem under control. So you start tapering off and tapering. Now, how do you know the minimum you can give? Well, you pretty much only know that by overshooting the mark and having to come back. So basically they dropped it down to probably once every day, then twice a week, down to once a week, and then now it's flared up. So I boosted the dose back up to every hour for 24 hours, and I reviewed the next day before she went off on holiday, and then I tapered it over the holiday. She was in the UK anyway. She had a phone contact. She wasn't that far away. If it was really bad, she could have come up. But she was empowered to all this. She knew what she was having to do. And then after the post-holiday, in a week's time, she came back and it all resolved, and she gradually tapered back. Now, interestingly, though, now, she is now, when I last saw her, she is on twice a week. So the hospital's decided as well that they're keeping her now on twice a week, not once a week, to keep this inflammatory process under control. But if I'd just done that to her and things had gone pear-shaped on her while she was out, I could have been, it wouldn't have been a good place to be. But she was completely part of the process. She agreed with everything we've said. If she'd said to me, no, I'm not happy with this, I'd rather have a consultant ophthalmologist look at this, I would have referred her, and it would have been the right thing to do. So now, logic for optometrists, especially actually with things like MECs coming online all over the shop, I think this is really important. When we're taught at school, at uni, we're taught to paint a picture of something and say, right, that's what it is. We look at a picture in Kansky and we say, yeah, that's what it is. That is not the way ophthalmologists or medics learn, and they use a thing called a medical sieve, which again, some of you may have heard this before. But all you've got to try to do is bring it down to an area. So remember, your working hypothesis is your best, or your working diagnosis, I should say, is your best hypothesis. And so long as you can bring it down to one of those four things, is it degenerative, is it infective, is it inflammatory, or is it traumatic? Now, there's more than this. In the medical sieve, there's about 7. There's also cancer and so on as well. One's age, but I always think of age and degeneration as kind of the same. And to try to simplify it, just down to that nice little thing, DITI. And so long as you can sieve it down to one of those areas, you're on the right track. You may not make a definitive diagnosis, but if you know it's at least inflammatory, then you're going to treat with an anti-inflammatory, aren't you? If you know it's traumatic, you're going to remove the trauma. If it's infective, you've got to then pick what infection it is and treat that and so on. And so what you've got to try to do is describe what you see when you're looking at the picture. Do not simply assume what you think it is. Don't dive straight in and say, oh my God, that's a such and such, that's it. Think about it, describe what you see. And I know we're all taught, is it red, is it painful, is it blurry? They're the 3 biggies, but actually laterality is really important. Is it bilateral? And I don't think we bang on enough about that. And how rapid it is, any associations, and also patient knowledge. Patients know a lot. A person with iritis, for instance, will come in and say, I'm having an iritis. And because they've had 3 others previously, they know. So patient information is often very good, but laterality is really important. So please try to start sieving what you do. Think logically, have the time to do it, and think about things. Don't jump to conclusions. It's not a good way to do it. And there'll be no logic to it either, incidentally. So a male contact lens wearer. Now, as soon as you've got a contact lens wearer, you think, uh-oh, contact lens problem. Emergency appointment, 24-hour history of sudden onset, ocular swelling, irritation, left eye only. How do you know that? Well, it was pretty obvious, but yeah, you can have a secondary thing in the other eye. You've got to look at the other eye. So we could confirm the other eye is absolutely spot on the button. Only the left eye. And as you can see in that picture, well, it's a 2D picture, I know, but I hope you can tell that that's quite chemotic, that's swollen. All that conjunctiva is swollen. He reckons he rubbed his eyes. The lens felt a bit uncomfortable yesterday. He removed it, but the vision is excellent. Vision, excellent. And obviously you're going to put some fluorescein in. You're going to check that cornea is clear. And this is all within the conjunctiva. So what's your specific diagnosis? What's your sieve character? Now, when I do this live, I try to get the audience to say. Now, I'm going to suggest to you that if you sieve that, you're going to say it's inflammatory. Now, you don't know what the trigger is. Is it because he rubbed his eyes? Was it a contact lens related? I doubt it, but was it contact lens related? But we know that there's no infection. We've put the fluorescein in. We know the other eye is okay. We've put the fluorescein in. We know that cornea is clear. So what can really go wrong? So it's inflammatory, isn't it? Now, if you did nothing at all, that would probably go away, actually. But these people pay me money. I put in a weak steroid, fluorometholone, to clear it up quickly for the gentleman. And it cleared up very, very quickly indeed. But I don't know. I still don't really know what cause it was. I simply know that it was inflammatory. I treated it. It went away. And I did follow it up, obviously, meticulously followed it up. So here's another patient. Now this one, seriously, this one will turn up in a MEX service. I'm not quite sure I really get MEX, to be honest. When I gave this talk, someone said, well, if that was on a MEX service, we'd be referring it. Well, I think, well, okay, it just seems to weaken the service. But 67-year-old male, emergency appointment, 2-week history, right? Again, 2 weeks. So, if it was something really serious, he wouldn't have blundered on with this for 2 weeks. He would have come in pretty promptly. Irritable right eye. The GP prescribed hypomelos, chlorphenicol, no help. Nurse sends to you. And that's exactly how a MEC service would work. They are expected to send them to you. So what are you going to make of that? Again, fluorescein, well, in this case, lissamine green, there's no corneal staining. Those little green blobs you see around the inferior part, they're raised. And it's a pretty uncomfortable eye. So describe what you see. Now, significantly in this case, if you go to the other eye's got some similar sorts of findings. The inferior part of the cornea isn't well covered in tears. There's nothing like that, of course, but it doesn't look comfortable. The lids are in poor shape. So describing what you see is important. And although he's come in specifically for that right eye, the left eye is actually a little bit the same. So what about a SIV category? Is it going to be degenerative? Is it going to be traumatic? Is it going to be inflammatory? Or is it going to be infective? Now, I'm going to suggest to you that, again, it's inflammatory. It could be inflammatory because of degenerative changes. So in this case, because both eyes are slightly affected, or not always slightly, but because they're both affected, it could be something to do with a more chronic problem, actually, because it's bilateral. But the actual acute episode is pure inflammation. So again, I diagnose it as exposure-induced acute limbitis. Someone else might make a different diagnosis, but the bottom line is it's inflammatory. So again, it was pretty bad, so I gave him FML for the acute limbitis, and we resolved it very, very quickly indeed. But then we did write to the doctor to talk about getting Clinitas, because this is more inflammatory because of exposure and because of poor lid tone and so on. So I do think there needs more chronic care with this patient as well. There's no point just dealing with that, because that's an outcome of a fundamental problem. It's not the actual problem itself. So you're going to have to deal with this patient because their lids and tears are poor. But again, bilaterality really played a role in how you deal with this. So I'm quite happy using steroids. I think if you're convinced that it's inflammatory, if you've checked the cornea, not a problem. And you can deal with these problems far more quickly. And ophthalmologists do this all the time. Optometrists are so scared of using steroids. Ophthalmologists think, well, what the heck are you're just mucking around otherwise. So here's another one then. Female 50. General health is good. No medications. Right eye red, aching for several days. And patently, you can tell from that image, I hope, that you'll see lots of flare in the anterior chamber. And this patient patently has an iritis. So, other medication, or other information, I should say, prior to treatment. The general health was good. It was the first episode. That's really important. Has she ever had any other episodes? No. It is unilateral. It is one eye only. Now, you've got to check that to make sure, but it's one eye only. That's really important to whether you treat this. Interestingly, though, she did say she had lower back pain, and that sparked a little thought in my brain. So now, she was a very fit lady. She did a lot of running. It could just be she has lower back pain, but the fact she had it did trigger. So any other additional tests? What's your clinical management plan? What indeed is your diagnosis? Well, we all know it's an iritis, but what is your clinical management plan? Are you going to refer? Are you going to treat? Are you going to liaise with the GP? Well, what I did, because I'm quite happy if it's an acute idiopathic iritis, anterior iritis, obviously, and you've looked at the back of the eye, you know there's nothing further back to worry about, I'm quite happy treating. And I treat like that. Week 1, every hour. Week 2, every second hour. Then 4 times a day, twice a day, and once a day. But I also referred her for blood screens. So I liaised with the GP, and blood tests are pretty cheap, so I thought, well, we might as well just do it, because I had this thought, is it ankylosing spondylitis? So I wrote to the GP and asked for HLA-B27 and others, CBC, ESR, anti-nuclear antibody. So I asked for all those things. How do I know that? Well, let's have a look at this. So this is where we're dealing with the GP, the patient, and the optometrist. All of them are part of the process now, and they're all included. And everything I do, I explain to the patient. And the patient, yep, I'm happy with that, please do it. So how did I look up the blood screens? Right, Medscape. If you're not on Medscape, get on it. It's fantastic. And it tells you things. You can look up iritis and it says, right, if it's first episode, if there's no red flags, so there's no general health issues, they're not got acute rheumatoid arthritis or anything like that, then you just treat the episode. By the 3rd episode, if they've had 3 idiopathic iritises in a row over time, then you call in further tests. So there's no rational reason to call in bloods or do anything, you just treat it. If it's bilateral, totally different animal, of course, and that's just logic, right? So logic for dummies, right? Logic for us lot. Just think about it. You don't have to be a clinician to figure this out. What are the chances of someone having an iritis in both eyes at the same time if they haven't got something underlying it? It's just not possible, right? And so if they came in with bilateral, you have to be rushing these people off. If there's any systemic red flags, then you may want to send them off. And certainly if it's granulomatous, you want to send them off. Because this lady had the lower back pain, I decided to call in those tests. And I find, now I already knew I wanted HLA-B27 because that's one for ankylosing spondylitis. But I looked up Medscape and it told me the other. So if you don't know all the tests to call, Medscape will tell you. So there's very few things in optometry that are so urgent that you haven't got time to sit back, collect your thoughts up and think about it. And so before I wrote the letter, I went on to Medscape to make absolutely certain I knew which bloods to actually ask the GP to do. Now, they all came back negative. The patient didn't have any of those things. But, you know, we've incorporated the GP. The GP's happy. The blood tests are very cheap anyway. And it just covered all our corners. So that was my logic to that one. Someone else might say, I wouldn't have called the bloods. And that would be perfectly legit, actually. But that was my rationalisation of why I did it. And I wrote it all down. So here's another patient. Way too scary, isn't it? Look at that. And you're going to refer it. Well, again, let's keep calm and let's just sieve this thing. What do we got here? Well, first of all, case history, mildly painful eye for 2 weeks, untreated for 2 weeks prior to presentation. Because these things are not that painful. That's an interesting one as well. Not very painful. These patients can live with this sort of stuff for a long time. This is not like an MK where they're going to come in screaming. So anyone that's lived with something for 2 weeks, you know, it's going to be different. Went to A&E, they instilled the fluorescein. I did not put that fluorescein in that person's eye. An advisor could be a foreign body and should go to the hospital, eye service. But they came to a community optometrist instead. So that's what we've got to play with. Now, you know, you're all looking at that hope and think, well, that's a dendritic ulcer there. And how silly is the A&E? Well, they're not. They've actually done everything right there, actually. They didn't really know what it was. No, they didn't tell the patient that, but they didn't really know. But they didn't just sit on it. They said they thought it was they must go to the hospital. So they have done everything right. They have referred on to someone with more knowledge than them. Okay, the patient decided to disobey that and come to us, but that was the patient's choice, not theirs. They had covered themselves because in A&E, in general A&E, they don't have all the kit, do they? So you can't blame them. They did everything right. What I then decided to do, though, was check the patient's medication status. Now, this is an important slide in another way. you've got to assess for medical red flags before you start treating things like this. And this is how optoms, on the left now, this is how optoms tend to write things down. They write down, this is what was on my case notes, actually. So I'm embarrassed to say that was what was on the patient's notes in our practice. So they've got these things, emphysema, high blood pressure, osteoporosis, all written down in a separate section. Then underneath a whole list of drugs, which, unless you really know what you're doing, they don't make any sense at all. And most of them aren't spelt correctly. Wouldn't it be better like that? So half the time I spend my time collecting things up and writing things out correctly. So we've got emphysema, COPD, and we're on some medications for that, some inhalers. We're also on prednisolone. Now that's an important one. So that's why we're on the prednisolone, because not because we're osteoarthritis or anything like that. We're on the prednisolone because of the COPD. We're also on carbocysteine, which is mucolytic for chest phlegm. But that prednisolone could be affecting their immune system a little bit. But importantly, they're not being used because they've got an inflammatory process going on that could already have reduced their immune system. So I was quite happy to treat this patient at this point. Now, 2 years ago, 4 years ago, I wouldn't have been. Not with that, I wouldn't have been. But I am happy now. But if there'd been something about their immune system I was really worried about, I'm thinking, I need to send this patient off. So taking a bit of time to look at all this stuff is actually critically important, and being logical about it. So there's nothing in that case history there, that medication list, that puts me off. So what were my hypotheses for this then? I had two. And what would be a clinical management plan, and what would be a review schedule? You can have a think about that if you want to go ahead, but I came up with two things, and I treated it sus. So first of all, my first hypothesis is it's active viral epithelial infection. But because of the dramatic stromal infusion, remember this was put in by Amy 4 hours before. She walked in, you just shine a light across the room, you could see it. So I decided that was now becoming interstitial keratitis. IK, interstitial inflammatory immune system. So they are quite elderly. The condition had time to bed in, so I hit it hard. I gave them ganciclovir ointment 5 times a day, and I gave them 400 milligrams of acyclovir 5 times a day initially. So that was for a couple of days. Then I reviewed her back, and at this stage now, the cornea the active viral infection is getting a lot better. We've got that nicely under control. But as you can see from the cross section there's still a lot of stromal involvement. That stroma is pretty hazy. And I've decided that's IK. It's relatively white, and there's no significant pain, which is really important. Necrotizing keratitis is painful. Interstitial keratitis is not. So that came into my second hypothesis, which is IK. And for that, I then added Pred Forte 2 hourly for the IK. But patently kept her on the antiviral stuff as well. Now, we're all told don't stick a steroid in a virus, and we know that, but you're treating two different things. And this was so beyond my red line some years ago, but logic goes along and you think, yeah, I know what to do with this, I know what to do with this, why not do it? And then once we tapered it off and I talked to the patient and said, look, there is a high probability this may come back, and if it does come back, we may have to treat it and even prolonged, a bit like that earlier lady on Zoster who's on chronic Pred Forte all the time because this has been allowed to bed in for 10 days. So there we are, keeping the wheels on. These are just examples that the actual cases weren't important. It was the outcomes and the way your logic works and the processes that I put in place in my practice. You will have a different set of views, undoubtedly. You may agree with some of the things I do, but we have to think about these things. You have to be able to work with your colleagues, and each person work to your own plan. And gradually through that, or not even that gradually, quite rapidly, you get very, very confident, I think, at dealing with some relatively aggressive things in the community if we want to. So that's for IPers, new IPers, and people wanting to do IP. I hope it helped. It's really good fun. Please do it. Thank you very much.